In this sepsis part 2, I'm going to cover some of the other aspects of the management of sepsis. The first, we'll talk about the source control. Source control should be identified as early as possible or excluded as rapidly as possible in patient with sepsis and septic shock, and that any required source control intervention be implemented as soon as medically and logistically practical after the diagnosis is made. Because if you identify the source and you manage it, the outcome in a sepsis patient would be much better. There are certain foci of infection which are readily amenable to source control, like intra-abdominal sepsis, gastrointestinal perforation, ischemic bowel, volvulus, cholangitis, cholecystitis, pyelonephritis associated with obstruction or abscess, necrotizing soft tissue infection, other deep space infection like empyema or septic arthritis, and implanted device infections. These are the infections which can be easily managed, and if you manage them, the outcome in that patient would be very good. It is suggested that you should have a target of about 6 to 12 hours after the diagnosis is made, that within 12 hours you should control the source, or it is as early as possible you should do the surgery. Whatever measures are required, you should do it. And what kind of optimal source control method you would apply will depend on the benefits and the risk of specific interventions, risk of transferring the patient, potential delay associated with specific procedures, and the probability of procedure success. So all these will determine what kind of method you are going to use in a patient to control the source. If there is an intravascular device, if there is no other source of infection, you should remove it. But if it is a tunnel catheter, and in the absence of septic shock or the fungemia, you could still salvage this by giving a prolonged course of antibiotic therapy. So in addition to the initial resuscitation, if a person requires fluids in a patient of sepsis, then you use a fluid challenge technique where fluid administration is continued as long as the hemodynamic factors, they continue to improve. That's why it is said that you should have some kind of hemodynamic monitoring to give further fluid in these patients. So what kind of fluid you should give?